Nevin, over to you to present the first case.
Thank you, Dr. Rajan. So before I start, let's put you into the setting and the environment that my case is from. So I'm a general practitioner practicing in primary care as a GP, as a medical doctor in private care. I'm based in Durban in South Africa, that's on the East Coast. It's a seaside town. So my case is from the beginning of the fourth COVID wave that we've experienced in South Africa, and the Omicron variant had been identified at that time. My case is of a new patient, so I've never seen this person before. It was a 54-year-old female, and she presented with an acute shortness of breath, which had started about 24 hours, well, in the last 24 hours. She could not complete her sentences. She looked unwell. She describes a flu-like illness for about a week preceding. She says she has not been treated, she has been treated for wheezing as a child, but has not been on any particular therapy. And from my side, she had not been vaccinated with a vaccine.
Nevin, as a primary care physician, what all comes up here in you? Is this bronchitis? Is this COVID? Is this anything related to an allergy, a drug allergy, you think?
So, with the acute presentation, and with our brain waves being constantly bombarded with COVID the past year, the only thing that came to mind was, could this have been COVID? This patient was distressed. The flu-like illness fitted in. The history of no vaccination fitted in. And it was the typical presentation that most of our patients were coming in with at that time. With the history of wheezing, it alerted me that there might be something else to this. But again, very aligned with the flu-like illness and the COVID pandemic that we have been experiencing.
Sure.
This patient was quite distressed, could not get a decent enough history to go into details with her. So I had to act.
Sure. And no, just to understand, Nevin, would you see these patients in clinic, a patient who presents like this, or would you see them online, just for primary care physicians to have an idea with this kind of a history in today?
This kind of patient would normally present in a face-to-face with myself. I rarely do practice virtually. I have done a few consultations, but it is not simple because you cannot examine the patient. You cannot get the physical cues you get from a physical examination when you're seeing that patient.
Sure. Umesh, just a question to you, Umesh. If your secretary told you about this history, would you schedule face-to-face?
Definitely. I think, when the virtual consult is okay when you're following up a patient that's known to you.
Sure.
I think like this presents in some form of respiratory distress, generalized flu-like symptoms. You need to see the patient to understand what's going on.
Sure.
When they mentioned that this patient had a history of asthma but did not take the treatment for the reasons presented, then all the more need to see this patient because clearly there is something acute going on.
So the clinical picture, when you eyeball the patient, she was obese, she was distressed, she was tachypneic. We had managed to do a blood pressure on her and it was elevated and she was tachycardic. Her oxygen saturation was low, around 82%. On examination of her chest, there was reduced breath sounds and a minimal kind of wheezing scenario, but not an overt asthma attack.
Sure. So this was obviously a patient who is hypoxic now, first time presentation, minimal wheezing, and a blood pressure that's elevated. Nevin, what do you do here? What do you do here?
Yeah, so typically what we do is we follow our ABCs. We make sure the airway is open, the airway is patent, which was obvious.
Sure.
We follow on to the breathing and then we assess circulation. So we were stuck on breathing with her. Typically what we would do is put a patient onto oxygen and then assess further on whether we need to nebulize such a patient or advance care.
But if you thought this was COVID, what would you do? Because I think there are too much panic in primary care physicians around that a hypoxic patient coming first time to their clinic is COVID. That's what we often see. So would you take any precautions there before you nebulize, or any other do's and don'ts?
Yeah, so the precautions are already set at our practice and at most practices in the area.
Yes.
Full PPE at all times, social distance, one patient at a time, no family members or non-patients to be in the consulting room or in the vicinity of the patient. We have access control with questioning patients at the door. Are you here for a chronic visit? Are you here for something that might be a flu-like illness or a COVID-like illness? So immediately we kind of try to triage whether this patient is an infectious patient with the risk of spreading the virus, whether this is not an infectious patient. In either circumstances, PPE is on at all times. So the confounding factors we have in this kind of scenario is, what do we do next? In view of this being a distressed patient, she did have a mask on, but with a distressed patient, there's this constant urge for them to kind of pull the mask down so they can get more air, they can get more oxygen into their system. So we have a separate room, a separate space that is used for any kind of distressed patient that we suspect might be infected.
Love to hear what happened from here, please.
From here, it just didn't get any better. We had an oxygen crisis in South Africa, where we did not have enough oxygen and cylinders being manufactured or distributed in time to replenish what was lost. And I had just run out of oxygen at the practice that morning. And I'm stuck. Is this a COVID patient? Do I nebulize this patient with the risk of the airborne transmission of COVID? Do I administer steroids to this patient? Because there was this wheeze. And if I did administer steroids and it was the acute viremic phase, this would obviously make this a bad COVID infection and pneumonia and all of the consequences thereof. For sure, we knew that the patient required hospitalization. But we were sitting with time issues. We were sitting with a sick patient in front of us. What do we do next?
Sure, very, very challenging from what I can see here. And I would never have liked to exchange places with you, Naveen, with this patient. Umesh, any thought here? What would you have done as a primary care physician amongst these options?
We have to acknowledge we functioning in a COVID pandemic. So therefore it behoves us to keep that foremost in our mind when we're assessing this patient. So the correct assumption is this patient has COVID-19 until proven otherwise. The next step is what particular risks does this patient carry? So he noted in the history this patient may have been diagnosed with asthma in the past, but not on treatment. So we probably see a patient with a background of undertreated asthma and then probably developing a viral illness. And in the pandemic, it's COVID-19 until proven otherwise. And then when he made the point that this patient could not speak in clear sentences, and you then consider asthma, then on first principles, this has to be acute severe asthma, irrespective of the oxygen saturation. But we already know that the oxygen saturation, as he had recorded, was low. So I think very clearly his intention was to give this patient oxygen. We needed to administer some kind of bronchodilator. During the COVID pandemic, I think it would be difficult to nebulize, and I think our Thoracic Society, in line with the International Thoracic Societies, issued a notice or a guideline that we should avoid nebulizing. So there are other ways of administering a bronchodilator through a spacer. But this patient was hypoxic and this patient needed oxygen and needed to get to hospital as soon as possible.
Sure. I tend to agree there, but it is challenging. So, do you recommend administering steroids, Nevin, in your clinic? Would you give an IV steroid shot before sending this patient to the hospital, or would you nebulize? If you had a choice between the two, I would imagine the nebulizer would give immediate relief to the patient, but the steroid would probably kick in after an hour or two. So would you do both, or what would you advise the primary care physician in such a situation?
So prior to the COVID pandemic, I would have done both. I would have nebulized the patient and then administered it in view that this is an ill patient that is going to require hospitalization, and is by the time the ambulance comes through and transports the patient, the steroid would have started to work, and we were getting progress. With this particular patient, we're in the middle of our pandemic. I was short of options, quite literally. What I had decided to then do was to follow on my first thought was to put the patient outside, because we did have sufficient space in an outdoor environment, and I went against the guidelines, unfortunately, and I did nebulize the patient. I had also administered an IV corticosteroid, and I had called the respiratory physician to alert them of the admission.
Naveen, a quick question. You mentioned you ran out of oxygen, had run out. Was that your clinic oxygen, or was it the patient's cylinder at home?
No, it's the clinic oxygen.
So that's an important question, Naveen. I do not know a significant number of primary care physicians that actually stock oxygen at their clinic or keep a concentrator. Is this a case, or is COVID telling us that primary care physicians should either keep a cylinder or a concentrator at their clinic?
So this was my scenario as well. Prior to the COVID pandemic, I did not have an oxygen cylinder. Subsequent to that, with the amount of hypoxic patients, with bed shortages, and literally having patients die in front of you, we prompted to purchase oxygen cylinders and service them at regular intervals so that we can give oxygen in an out-of-hospital setting prior to them getting into a hospital setting.
These are things, how medicine has evolved, Naveen. It's really amazing and such important take-home. Please continue.
Yeah, so on the point of the technology and the advancements, if we look at just an oxygen oximeter, prior to COVID, we never kept oximeters in a primary care setting. It was expensive machines attached to ICO devices. After COVID, we got these little finger things that you'd stick on that are battery operated, that are fairly inexpensive and fairly accurate. It makes me wonder how many distressed patients or asthmatic patients that I've nebulized and sent home that were hypoxic at the end of it, because you wouldn't know without have testing.
Absolutely, it's helped me actually counsel my sleep apnea patients better about hypoxia in the night, because everyone seems to have a pulse oximeter. And interestingly, a friend of mine on a flight, when a patient was breathless, couldn't find a pulse oximeter in the emergency kit of the aircraft, but every passenger had one. So that tells you what has happened with pulse oximeters. So please carry on, Naveen.
So the patient was admitted and was taken under the care of the pulmonologist. The COVID test happened to have been negative, which surprised everybody. The patient improved on in-hospital management of an acute asthma attack. And after the PCR was negative for COVID, the physician had then done a extended spectrum test and had identified swine flu, H1N1, as the virus that was causing the entire incident. Patient thankfully recovered fully and was discharged home.
Fantastic. A few thoughts here, before you go to your concluding slide. This patient was probably, detected with H1N1, and I keep getting this question asked now by people who are traveling, because not many countries yet have molnupiravir and the other new oral drugs. Should you carry oseltamivir with you when you travel? What's your take on that, Naveen? Do you put it as part of a travel kit for your patient?
No, not at all. We're always cognizant about antibiotic abuse and antiviral abuse.
Yes.
when we did have swine flu outbreaks previously, we were not one to run to the Tamiflu as a first line of treatment. We managed the patient, and if there was reason for more advanced care, then we would initiate or add on the antiviral. To put it on as the standard regimen, especially once we know that the swine flu is now endemic, it's everywhere, it's part of your normal flu spectrum, and it's causing annual flus. I wouldn't necessarily add it into a travel pack.
Sure. Please carry on.
After the patient's discharge and she had sufficiently recovered, got to ask her a few more questions. She was diagnosed as an asthmatic at a younger age, but she was never shown how to use an inhaler properly. So she abandoned them. She just figured, this little thing does not work. Why should I continue using it? And she got these wheezing episodes about twice a year after having flu-like illnesses, and probably sometimes outside of that. So it was interesting to know that this was an asthmatic attack, and it was probably precipitated by the infection that she had.
Sure.
But I'm glad the patient is well and has been has recovered fully.
Right. I was just wondering, so obviously if this was a previous diagnosis of asthma, this patient was never given an asthma action plan. Am I right, Nivin?
Right.
Absolutely.
Yeah, and neither asked to use a peak flow meter. Any thoughts for primary care physicians listening in? And Nevin, what made you so interested in respiratory medicine in primary care? May I ask? Because primary care physicians listening in, there's suddenly so much for them to do. Is there any thoughts you have for them in terms of primary care management of asthma, especially related to this case?
So I think the interest is sparked from the environment you're working in, right? So we're in an environment where there is an area in KZN that has industry, and there's a lot of asthma and bronchospasm as a result of pollution in the air. We're also in an area where there's a lot of allergic rhinitis and allergens in the area. Being a coastal town, the humidity is elevated. There has been identification of some fungal spores that causes. So annually, or maybe even 2 or 3 times a year, we get numerous patients attending with respiratory illnesses, and often it's an asthmatic attack, sparked on by the allergic response and in some areas by the pollutant effect. This has sparked that interest to say, let's take this further. Let's be more interested in what's happening. When you're working in a busy environment, like a busy clinic environment in an emergency room, in your younger days, every person that came in with an irritant or a cough or an infection, you just antibiotics and go home, and you don't have that follow-up. But working in a family GP practice, in Durban we call family practitioners or house doctors or family doctors, you get to understand the family, see the trends between the parents having asthma, the children having asthma, the allergic syndrome that goes between the skin, the nose and the lungs, and you treat that as a holistic event.
Sure.
Asthma is not difficult to treat in a primary care setting. It is easy to pick up. It is easy to treat. You do have cases that will require specialist care, and that's a given for anything. And that's why we have our specialists available. But to understand asthma, to understand how to treat your acute episodes, and to manage chronic episodes, I think should be in the spectrum of any primary care practitioner.
This case was really fascinating, and one thing that really stood out here was, in my opinion, was a lot of denial on the patient's part all these years. Diagnosed at a young age, she's now 54, and probably suffering more than she ever claimed in the last few years, but tolerating it. So this is one big issue we find in asthma. I think there are so many issues that we need to cover in primary care management of asthma.